In Monday's lecture, it was online, we had this chart, and so I put the answers at the bottom. You can take a screenshot of this if you'd like. I'm trying to make that bigger, but it's not going to work. This is comparing and contrasting the differences between intramembranous and endochondral ossification. So if you haven't watched the lecture yet, and judging by the number, like the analytics, not everybody's watched Monday's lecture, so I would definitely encourage you to do that. It's one of the beautiful things about YouTube, right? You can kind of track views and see who's actually staying up with the material. Okay. Next order of business is what's happening on Monday? Exam 2. We've got a few study sessions that are coming up. So we have Thursday 5 to 6, Science Annex 122. Thursday 7 to 8. Correct, Amara? And that's in 242? WETA 242, Thursday 7 to 8, also on Zoom. And then Sunday 3 to 4 in this room, but also on Zoom. And the Zoom ones will be recorded as well in a last safety net effort if you can't attend by Zoom or in person. Okay? But you're going to have a participation opportunity at one of those review sessions. And let me reiterate, those are not bonus opportunities. Those are, per the syllabus, those are actual graded points. And they're low-hanging fruit. You attend, you participate, you get the points. Okay? Now today, we're gonna hand out bonus opportunity 2, so you need to stay to the end. That'll be due by Sunday evening at 11:59 p.m. You'll have an hour to do it. I'll explain it at the end of class. Friday, you have a quiz due, right? Quiz 6, is that right? If you haven't done it yet, it's over the skeletal system. So kind of a lot going on in preparation for the exam. Similar format as last time. There shouldn't be any surprises. Couple questions that came. What about review material? Will there be any review concepts from Unit 1? Yes. Small amount. 10% or less. So 5 questions maybe of review material. Nothing major. Most of it will be over skin and bones, integument and skeletal system. Today is our last lecture of 3 in skeletal system, so this is game on for Monday's lecture. Okay, questions on any of that? We good? How do you get a pig to the hospital? How do you get a pig to the hospital? In the ambulance. I think that was one of my kids a long time ago. They're so funny. Okay. What's a thing, but not, as a dad, you have to laugh at those like profusely when they write them, right? Okay. That's the job. What's a thing, but not a thing at all? Wow. I mean, we'll just stop right there. It's so darn good. What's a thing, but not a thing at all? Nothing. Okay. It's getting worse. It's getting worse. What's a cake's position in baseball? What's a cake's position? A cake. Batter. Nicely done. Okay. We're gonna do one last one because maybe this is like maybe a replacement. You choose which one it replaces. What does a lost sock look for? A lost sock. It's soulmate. Nicely done. Nicely done. Okay. All right, now we got sort of the the giggles out. That was I appreciate the enthusiasm. I mean, it was one of the worst jokes, but one of the best responses. That's what matters, is how you respond. Okay, so today's going to be very clinically focused. For those of you going on in your studies, you got your eye on the prize of clinical medicine in some capacity, or clinically relevant research, clinically relevant field, which is one of the reasons I really like this class. There's a lot of application. So today, we're going to really get into some of the diseases associated with bone and bone health. And the first one up, if you've previewed the slides, is osteoporosis. Now, in between some of the lectures and after class and in office hours, many of you have asked about this. And so here we are. We've talked a little bit with some of you in office hours about osteoporosis, kind of wondering what it is. But for the rest of you, we're going to get everybody on the same page. So the images on the lower panel, on your lower left, your very lower left image, is a decellularized view of bone post-mortem after death, healthy bone, far left. Right next to it, slightly gray, is osteoporotic bone. So you can appreciate the differences: less density, more open space, less strong. You can see kind of the resemblance or the repercussions of abnormal curvatures as the bones lose their density with osteoporosis. So osteoporosis is a disease of the bones. And it manifests itself in an exaggerated thoracic kyphosis. So that's this, right? The hunchback. So some of you, it's time to sit up. That's right. Right? You're sitting up, shoulders back. I like it. Because this is actually what happens as we age. And if you look at profile images of elderly patients, and I don't know what's going to happen with all of these and with all of these that we keep using, right? Because what is the normal posture? This is how I see people walking around campus. I mean, this is going to be severe in your future patients. Absolutely. So osteoporosis is a loss of bone mass. The cancellous tissue is impacted. It is most common in elderly women, but men succumb to this disease as well, just delayed. And we'll talk about that here a little bit. The onset for women is menopause, and menopause is the end of the menstrual cycle. The blood circulating levels of estrogen plummet, like dramatically, and they fall off quickly. And estrogen has a bone protecting feature to it. Testosterone, the sex androgens, both have this bone protecting feature. But in men, the loss of testosterone is more of a slow decline, versus with women, when the menstrual cycle is over and the child rearing is done, the estrogen levels drop aggressively, and in men, it tapers off slowly over time. So that's the big difference here. The bones become very brittle, as you can see in these pictures. Everybody can appreciate healthy bone on the left, this right image, osteoporotic bone. Pretty clear? When you're talking about the hip, the wrist, the vertebral column, these are all areas of high force, like on a slip or a fall, and so they're very prone to fracture. And in the subpopulation of females, Caucasian and petite females are at the highest risk. And so, with race, Caucasians don't have as dense of a bone normally as other races. Secondly, petite females have less forces on their bones because there's not as much mass, and so therefore their bone architecture is not as dense as a non-petite female. Does that make sense? So these are kind of the highest risk categories that we look at. We're going to talk a lot about prevention today, and we'll talk a lot of that about prevention in the category of education. So we're going to talk about maximizing bone density in childhood and in adolescence. We'll talk about physical activity. We'll talk about diet, not just in females, but in males as well. We tend to hyper-focus on females because they're the category at highest risk. But what applies to the females also applies to the men. And then we'll talk about some of the treatments or drugs and strategies associated with managing osteoporosis. Okay, so just a higher magnification view of that image that I was focusing on. Probably a good image to be able to know the difference between normal and osteoporotic bone. You know I all like images, right? So osteoporosis, some facts. When bone resorption, or the breakdown of bone, is greater than the deposition of bone, that's how you would read that sentence at the top of the screen, right? You know, the alligator going this way. You guys remember that? Less than or equal to? You're like, I never could remember. Bone resorption, it's open on this side, so is greater than bone deposition. You're breaking down bone more than you're depositing the bone, you lead to osteoporosis. So it's a disease of the bone that leads to a risk of fracture. The fracture itself is not osteoporosis. It's a loss in bone mineral density. The density of the bone drops. This microarchitecture is disrupted. Hopefully you can appreciate the microarchitecture on the right slide. Right image is much different than the architecture on the left. And the types of proteins, the non-collagenous protein, as well as the collagenous protein, is disrupted. So the World Health Organization defines this as a threshold. So if it's 2.5 standard deviations below peak bone mass that occurs in a 20-year-old female, that's, on average, that's this class. So ladies, it's as good as it's going to get right here, bone density-wise. Okay? You have a lot of things to look forward in life, but bone density is not going to probably go up. Okay? So 2.5 times below your peak bone density, measured by a machine known as a dual X-ray absorptiometer, DEXA, DXA. It's basically a fancy X-ray device. And that's osteoporosis. So it's most common in women after menopause. We refer to it as postmenopausal osteoporosis, but it does develop in men. It can be in patients that have hormonal disorders as well. It's not just old people, as you're thinking. It could be a side effect from certain types of medications, specifically glucocorticoid therapy. And so we'll talk about some of the things and the ways to prevent and to treat osteoporosis. So nearly 10 million people in the United States have osteoporosis, and we're on track for another 18 million that have low bone mass that places them at a risk for developing osteoporosis. 80% of these patients are women, so that means 20% are men. Older than 50, patients older than 50, that's me now. 1 in 2 women and 1 in 8 men are predicted to have an osteoporotic fracture in their lifetime. So this is where, grandma falls, breaks their hip, and we're super nervous about what's going to happen, right? Because now they're in the hospital, they're recovering from a surgery, they get an infection, they catch the flu, and it's not a good outcome. And so that's why, hip fractures in elderly patients are really risky, and there's a high mortality rate. That's how that happens. It's not because they broke their hip. They don't die from a broken hip, right? They pass away because they catch some nosocomial infection in the hospital. They don't recover well, right? So keep them healthy, keeping them mobile, keeping them out of the hospital is a really important task for our occupational therapists, our physical therapists, nursing, physicians, dietitians. Okay, so let's talk about some of the treatments that many of you have heard of. Well, why don't we just give estrogen? Estrogen is a great therapy for a lot of patients. You can deliver it orally, or you can deliver it in a patch transdermally through the skin. Gets into the bloodstream because it absorbs into what layer? The epidermis or the dermis? Dermis, and even the hypodermis, because it's what? Full of what type of structures? Capillaries, blood vessels, so it gets into the bloodstream. That's how transdermal patches work. Some patients cannot take hormone replacement therapy. They don't respond well to it. They get nauseous, it doesn't agree with them. The hot flashes get worse. Hot flashes are basically temperature regulation in the body for women that are postmenopausal. Sometimes they're feeling cool, sometimes they're feeling warm, and they cycle. And the hormones that are moving up and down, that usually just cycle once a month, are cycling on a more frequent basis. So that can be uncomfortable. They can't sleep at night. Patients that are struggling or have certain types of cancers, like breast cancer, cannot take usually estrogen replacements. So we can use selective estrogen receptor modulators for these patients. So estrogen is a hormone. It binds to a receptor. If you can't deliver more estrogen, you can upregulate the receptor so that the estrogen that is present, the cells respond to it to a greater extent. This works really well for patients that want to be on estrogen replacement, but maybe are in remission for breast cancer, so you'll use a estrogen receptor modulator. Calcium and vitamin D, I think for some obvious reasons now, right? So calcium and vitamin D supplementation in the diet. Also, we have bisphosphonates, like a Beniva or a Fosamax. So these bisphosphonates give extra phosphate for the calcium phosphate that's part of the inorganic material within bone. Calcitonin. Calcitonin is a hormone that's typically prevalent in high concentrations in salmon and salmon-derived supplementation. It slows bone loss and it increases bone density. So calcitonin is a natural hormone that's found within salmon, which is a great component in young individuals' diets. Obviously expensive, right? So we have a challenge here. Eating healthy and eating well and eating balanced is actually cost prohibitive, right? And so a lot of our populations that can't afford certain types of food supplementation, because, who doesn't like salmon, right? But it's really, really pricey. So you're not going to be feeding 9-year-olds to 15-year-olds in school lunch programs salmon. We can also look at some newer therapies that are coming out. And this is actually a placeholder for a device that was made by Medtronic, which is using an infused bone graft, which is a bone morphogenic protein. So it's recombinant. It's recombinantly derived, so it's genetically modified. But it's a recombinant, that's what the RH stands for, bone morphogenic protein. It's the second variation of that. This is a growth factor that stimulates osteoblastic activity, bone building activity. So companies like this Medtronic have decided to put in a bone graft or a lumbar cage device, an appliance that's used on the lower back to actually fuse the spine. in fractured patients. They've impregnated the metal with a growth factor. You're going to see more of these types of devices as your clinical experiences move on. So, for example, putting him into artificial hips. So this is a schematic diagram of an artificial hip. Kind of one of the common fractures in osteoporotic patients is a hip fracture. So we're going to walk through an example, an osteoporotic example that came from a colleague of mine years ago. So this is a real patient that was seen here at FMC. MG is the initials of this patient, 73-year-old female, fell on the dance floor at her daughter's wedding. I mean, she was dancing, which is awesome. She was unable to walk and complained of moderate pain about her left groin and thigh. So here and here. Examination of the ED revealed good range of motion of the left hip, although it was painful, no deformity was noted. So here's a picture of MG's left hip. What do you notice on her right hip? What's that? It already had an implant, right? So, I mean, she's out boogieing and she had a replacement hip already. She fell and fractured her left side. Here's some images. This is a fracture where the red arrows are pointing to this percanteric fracture, right where those arrows are actually highlighted. You can kind of see this little line that comes down. So here's another rotated angle. You can kind of appreciate this fracture, percanteric fracture, a little bit easier right here because it's right on the white line that lights up radiographically. So here's what they did on the left hip. Not a complete artificial hip like she has on the right side. This one's 9 years old. And now she's got this on the left, which is utilizing her femoral head, native femoral head, but actually screwing into the proximal portion of her left femur. So my question to you all is, here's another rotated angle. You can kind of see this fracture here. See if I dim these lights, it might be a little bit more obvious. Is that better? You can see that fracture, see the fracture there, and then the fracture line here. So my question to all of you, group activity, is here's some details. Patients on aspirin and Coumadin. What's Coumadin? A blood thinner, okay? Anticoagulant. Keeps the blood from clotting. Patient has high blood pressure. What type of gait issues do you expect the patient's going to experience? And maybe give me answers like immediately post-surgery, maybe 6 months out, maybe 1 year out. Gait issues means like how will she walk? What kind of walking problems, challenges, abnormalities might she experience? Okay, secondly, what kind of dietary suggestions might you provide? And then any exercises. So we're pretending today, right, that we're a physician, a physical therapist, dietitian. So talk amongst yourselves and think through this whole scenario, and then I'm going to ask you for some feedback. I'd love to hear some of your thoughts. It doesn't have to go in order. So raise your hand if you've got some ideas or thoughts about any one of these questions, things for consideration. Yes. So for a gait analysis, you'd probably have more of a waddle or a limp. You know, she's probably going to be wheelchair bound to start, right? Post surgery, and no bathing until her wounds completely heal from surgery, right? They had to open up her hip to implant that appliance. Then from there, she'll probably get out of the wheelchair and waddle to the restroom or limp to the restroom, use bars and handles, maybe a walker to get to and from. Probably have medical assistant or someone helping her immediately post-surgery. When she's released to go home, wheelchair, walker, maybe at that point, a multi-point cane, right, to get to and from. Any other gait things that you're going to be thinking of? Yeah, I would agree. So having a titanium head on the right and then a native osseous head on the left, as time moves on, you'll probably see more exaggerated left-right discrepancies. Okay, there may be leg length differences that you measure and notice. You may have to have orthotics. You'll do gait analysis, right? From a PT standpoint, you'll be paying attention to that. What kind of shoes patient's wearing? Okay, good. What else? Gait, that's good. I completely agree. Yeah. So she's 78. Comorbidities are a thing, right? Let's have you walk through some of those early things here just so we can get it on the recording. Oh, that one's not working. How come that one's not working? You have to borrow this. I want you to go through the medication stuff. Because this is a big deal, right? So she's on aspirin and she's on Coumadin. And aspirin is actually an anticoagulant, like a low-level anticoagulant, as well as Coumadin. Okay, keep going. Yeah, just say it all, because I want to get on the recording for those. There's at least 2 people that are sick today. And she has high blood pressure. We already know that. Yep.
Yes. I don't know if she's on alpha blockers, beta blockers, calcium channel blockers. I have no idea what blood pressure medication she's on, but those medications can also affect her surgical recovery. The main concern, however, is anti-inflammatory drugs like ibuprofen. What they do is they go in and they pull what they see as inflammation markers in the blood away, and they get rid of it. They extrude it. Aspirin and Coumadin both do this thing, so if she has to stay on this medication through surgery, this is going to drastically affect the post-surgical recovery time and the remodeling of the bone, especially with implantation.
I wouldn't be surprised if you see pharmaceutical modification for the first few weeks after surgery where they get rid of Coumadin or they drop the aspirin or they lower the dose on both so that she can be on some sort of pain medication post-surgery. Now, we're really not giving in. We really refrain from aggressive pain medications like narcotics because of recent events that have happened within medicine. So you're kind of limited to like Tylenol and ibuprofen. Some surgeons are still prescribing certain narcotics for a certain period of time with 0 refills. But yeah, that's something that will have to be very, very closely watched. I agree. The other one is vitamin K. So from a diet standpoint, anybody know what vitamin K is? Where does it come from? Vitamin K. What foods are rich in vitamin K? Green leafies, okay? So vitamin K also serves as an anticoagulant in high doses. And so if, as a 78-year-old, if she's active and she's, she likes vegetables, that piece of information probably needs to filter in there too as well, right? A lot of moving parts here. It's not just, put in a new device, send her on her way, write a script for PT, I'll see you in 6 months. Okay, great discussion. What else? Any other dietary suggestions? I brought up the green leafies, but what are some other ones that you might recommend based upon what you've learned already, what you know about bone remodeling? Foods that are high in calcium. Our future physical therapists, give us some ideas on how you're going to get MG moving. Is it important for her to start moving soon? She's an active lady, right? I mean, she broke her right hip and now she broke her left hip. And she was dancing at a wedding at 78, right? She's hypertensive with lots of comorbidities, but she's going to go down swinging. We know that. That's awesome, right? Like, hey, that's what you want, your patients to have quality of life. So what are some other things you would recommend for her to say, hey, let's get you back on the dance floor quickly, but not too quickly? Yeah.
Which are just super low intense, slow things. And then by doing walks, it's helping them. Mobilization is good, and they're not worried about tripping on their feet. And then once that proceeds, leg, we're having put a little bit of pressure down on their leg as they're pushing up. So that helps a lot with the mobility, as well as just like.
Yeah. Water therapy. Like after she's cleared for bathing, obviously, you don't want infections at the wound site. That would be bad. Okay? What about weight bearing? Oh, sorry.
Oh, never mind. I was just going to say that I would imagine you would probably want to do some like extension and flexion exercises later down the road to get her
range of motion,
extension
and flexion. I was about to say weight bearing exercises. Why is weight bearing activity going to be important once she's fully healed?
Bone growth.
It promotes the bone remodeling according to which law? Wolff's Law. Very good. Taking walks. Now she's cleared. She doesn't have a cane. It's a year later. Walks outside. Why do I want it to be outside during daylight hours? Vitamin D absorption. Okay, you guys are putting some stuff together here, right? So we're just kind of pretending that we're clinicians here, myself included. This is the best way because you don't have to deal with like grumpy patients, right? It's just some theoretical thing on the board. But it's kind of fascinating to see how all this stuff fits together. This is what you're going to be doing in the future. And so all of the stuff that you've learned about chemistry and biology with anatomy and physiology all intertwined, now you're playing clinical provider and you get to synthesize all this information. I think it's kind of fun. Okay. We done pretending? All right. So this was a study, and I think you're going to see more of this. This is just a study that was published a while ago, like a quarter of a century ago. 24 years ago, in the year 2000, this was published. And this was like the father of regenerative medicine, Langer and Vacanti. Oops, sorry. Langer and Vacanti published this in the year 2000. And what they were doing is they were actually modifying these bone defects with mesenchymal stem cells. So stem cells in a scaffold. Here on the far right is this empty defect. They cut a hole out of the bone in this animal model. And after 16 weeks, some of it grew back. Can you kind of appreciate how much it grew back in the control on the far right? Well, if you load a carrier, the carrier type is not important, but this is a carrier that mimics the bone matrix. You load it with mesenchymal stem cells, and you get a much more well-pronounced bone growth in 16 weeks, even in 8 weeks, than you do in an empty defect. So again, you're probably going to be seeing, it takes time. I mean, this is nearly a quarter of a century ago. It takes time for things to move out of the research environment and into clinical practice. But like what we saw with Medtronic, where we're using growth factors to promote bone growth, you'll probably see stem cell therapies along with growth factors promoting orthopedic applications for patients like MG and others. Okay, just something to look forward to. Okay, let's talk a little bit more about bone health. The disease that I'm talking about right now is kind of this interplay, going back to osteoporosis, this interplay between excessive bone resorption, which we talked about in the very beginning, and what cells are responsible for excessive bone resorption? Clasts, osteoclasts. And then inadequate new bone formation during remodeling. So what cells are those? Osteoblasts. And then the third is inadequate or inappropriate peak bone mass in those particular individuals. So a question for you all: what's the most important age range for taking action to prevent osteoporosis? In our MG patient, 61 to 80, D. My age range, 41 to 60. Some of you, 21 to 40. Some of you still up until 20 years of age. What is it? It is A. It's absolutely A. Because the peak bone mass is at about 20 years of age. So you can kind of see this bone mineral density graph on the y-axis, and here's age on the x-axis. And in the early 20s is when we actually hit our peak bone mineral density, and then it's flat until about 50 years of age where you start to see this drop. So the concept is like, sort of this bank that you have, or this storage that you have, or reserves that you have of bone density. And so what you're trying to do, what we're trying to do, what I want you all to be doing as you move on professionally, is educate that 0 to 20-year-old population, educate that 20 to 40-year-old population, educate that 40 to 60, that 60 to 80, and understand that some of those, early years are actually really critical. And so the concept is, if you're here with a high bone density when you hit menopause and you have this expected drop, you're going to stay still in this low risk category. The issue is if you're starting out at a peak bone mass that's lower and you hit menopause, that's when you hit this drop and you enter into this high risk category. So the question about, men. Do men get osteoporosis? Yes, they absolutely do. We talked about this. It's just delayed. It's later in life because they don't have the sudden loss or sudden drop in sex hormone circulating that women do. Other risk factors associated with osteoporosis are excessive alcohol use, smoking, corticosteroid intake. So there are certain immune compromised individuals that are on high amounts of glucocorticosteroids. And so those will have side effects associated with bone mineral density. And so of the 10 million people in the US with osteoporosis, about 20% of them are men, 2 million out of 10. So let's look at a few more graphs. I want you to read this graph and I want you to answer this question. What's the average bone mass for men in their 80s? Average bone mass for men in their 80s. So let's take a look at this curve. Men in their 80s. Take this across. Under 1,500, above 1,000. Pretty close to, 1,300 grams, I would say C. We talked about ethnic differences, right? The group that's at the highest risk is Caucasian petite females. Okay, so we can see under different ethnic classifications and males and females. So the question here is, what's the standard average hip bone mineral density? That's what this graph is showing for a black male at the age of 70. So it's going to be the dark circles. So it's this tracing here. So you can hopefully what you can appreciate is everybody declines. Do you see that? All of these graphs at the age of 20 are all dropping. They're all dropping. And if you look at the black male, just under 1, so 0.98. Okay, so you're going to have some ethnic differences based upon your patient population. Okay. Slightly old. The recommendations haven't changed much at all, believe it or not. So the question is, are females consuming enough calcium in their diets? So this graph is showing adequate intake at the top. And what's interesting, in these early years, 2 to 5 months, 6 to 12 months, 1 to 3, 4 to 8, 9 to 18, we ratchet this up, and then from 18 to 19, obviously this graph is not to scale in the age, right? Because they're emphasizing 18 to 19. Look at this huge spike when the recommendations in calcium intake is at its peak. This is basically like 18 to 19-year-olds, like your senior year of high school to your freshman or sophomore year of college. Right? Then it kind of plateaus, but you have the spike at 1,400 milligrams a day, but really then here, it's like 1,200 milligrams a day until you hit your 50s, and then they ratchet back up to nearly about 1,300 milligrams per day. And then look at what's actually happening. Like, look at so from our food, and then from food and supplementation, there is this huge gap. You guys appreciate that? And that's the reason we have such a problem with osteoporosis in our elderly female population. So how do you fix that? You educate the next generation to educate the next generation. And this kind of starts right here in this classroom. And hopefully just spider webs from there. So teenagers and over 50-year-olds, 1,200 milligrams recommended daily allowance or greater. Adults 20 to 49 at about 1,000 milligrams per day. The reason it's so high is because you only absorb about 30% of the calcium that you intake. Vitamin D assists with the absorption, and that's why vitamin D is so important. Okay. Another complicating factor. There's a connection to this. So read this. You don't need to shout it out, but do you have a favorite soda? Maybe it's not listed, that's fine. Okay. We're not sponsored by any of these organizations yet. If Pepsi wants to hop on, there's room. We get some new upholstery for the chairs, Pepsi. Okay. So here's the connection. Here's the connection. What does this have to do with bone health? So you're like, well, what's the right answer? There's no right answer. Okay, that's not the point of the exercise. This is the point of the exercise. I want you to look at this bottom graph, bottom right. And I want you to see the femoral neck bone mineral density on the y-axis. And zero sodas per week. 0 sodas a week. Now, on the far right, 7 sodas a week is just 1 a day. That's not crazy. That's like, yeah, I don't think I drink that much soda. I mean, maybe I get a Polar Pop, twice a day. It's not that much, is it? A Polar Pop once a day, right? What are those, like 32 ounces? So that's like 2.5 cans of soda per day. The far right graph is a soda a day. And the asterisks demonstrate that you have a statistically significant drop in femoral neck bone mineral density by just doing 3 to 7 sodas per day. So why? What is it about soda that's actually impacting femoral neck bone mineral density? So this is the Framingham osteoporosis study. It's a fairly well-quoted study. And obviously, the soda industry wasn't real happy with this. But in this Framingham study that you're looking at, one of the theories was those individuals that were surveyed and then measured that had excessive soda consumption were possibly not drinking other things. So one theory is, well, they're not drinking milk. They're not having calcium in their diet. They're having a soda. They're not eating a healthy snack. They have a soda instead of having citrus or, a bar or, some nutritious snack. They have a soda instead. Soda's cheap, right? It gets back to my kind of conundrum of healthy food availability to all socioeconomic groups. But we have a big disparity here. Okay, so that's one theory. They didn't prove any of this. They just have theories. The only thing it demonstrated is this concerning drop. Now the question is, what's it from? But you're all smart. You're getting smarter. You can draw some of your own conclusions. Caffeine has had a long, well-established linkage in interfering with calcium absorption in the gut. So caffeinated beverages, which they did not separate out, may actually be the bigger culprit here. And then the last one is, if you look at this ingredient list here on this can, it says carbonated water, sucrose, caramel coloring, and phosphoric acid. So what's phosphoric acid going to do to your carbonic salts in bone if you have high amounts of phosphoric acid? It's going to break them down. So we don't really know the exact mechanism, but there's a lot of things that don't look good. Are you with me? And the data is actually quite concerning at having like one soda every other day, which really isn't that excessive. I mean, wow. Okay, there was another study that was this teenager study that I'm quoting here. And this was published in 2000. It was 9th and 10th grade females who have soda drinks on a regular basis. They didn't describe a regular basis, but probably on a daily basis. Demonstrated 3 times the risk of bone fractures compared to those that didn't drink carbonated beverages at all. And you know, the last study or last sort of comment is women versus men. So which population is this concerning to, women or men? Well, both, right? Both. But young women are at a higher risk earlier in life. But again, the answer is never like it's only a female disease. Are you with me? So we tend to focus on osteoporosis as being a female disease, and that's actually not correct. And men, you'll get there, all right? It's just a matter of time. And so a lot of these principles apply to both men and women. It's not just a female disease. I don't want you walking away with that conclusion. Okay, the last piece of data that I want to talk about today, and then we'll be finishing a little early, is weight-bearing activity. So this was a really interesting study, and this isn't new information. I mean, these are old studies that were done, and this study was in the mid-90s. So I don't know why more of this education isn't finding its way into pediatrician offices. Okay, so it's your job to disseminate this kind of information. So this was a study that was done in Northern Europe. It was done in Finland. Okay, so obviously these are Caucasian patients. And these were racket players. So racket players, whether it was tennis or squash. For those of you who don't know what squash is, Google it and you'll see, hit video and then you can watch squash. Okay, everyone knows what tennis is, right? These are racket activities that you play with a dominant hand. Now, you could use your non-dominant arm, but you primarily use your dominant arm. And so there's weight loading, there's force. They're doing this aggressively. And what this study was looking at as the difference in bone mineral mass between the dominant and the non-dominant arm in these female athletes. And they were tracking it before and after puberty. And so what you can see, they had controls. You can look at the difference. So the way you read this is, in the controls, less than 5% difference. So it's about a 3.5% difference between the right and the left arms in bone mineral density of individuals that were not racket players. So there's really no major impact of weight-bearing exercise. So for the exercise scientists in the room, for the future physical therapists, this is a huge plug for weight-bearing activity throughout your entire lifetime for bone health. So if you don't do anything, your bone mineral density between your dominant and your non-dominant arm is really no different. 3.5% difference. It's like picking up the pencil, right? That's like opening the house door with your dominant arm, doing all the things with your dominant arm. But if you look at the onset of rigorous training, if it's before puberty in these females, so we're talking 8 to 10, 8 to 11 years of age, 8 to 12 in some young females, and look at the huge difference, like 22% difference when they start weight-bearing activity as young children. And then if you wait until after puberty, you lose over half of that response. So it's kind of a plug to say, let's get our kids active at an early age in as many things as we can, right? Let's try to make food, healthy food options available to the kids. Like maybe we take, I mean, I know this is getting a little political, but can you take out the soda machines and put in like, you know, other things that are actually better for them from a diet standpoint? Okay, you with me? All right, I'll stop with the soapbox pitch, but these are kind of the application stuff that all of you will be equipped with as time moves on. Questions? Any questions in the back? Yeah, it's a great question. So the question is, I'll repeat it for the recording. Having a previous fracture in a bone, does that put you at greater risk of developing osteoporosis in that bone later in life? Not necessarily. So there have been studies that have looked at exactly that. And if all is going well from a health standpoint, when you heal, that bone is going to remodel even stronger than when it originally formed. And so you'll have a scaffolding that's even denser than when it started, if everything is healing correctly. So prior fractures, you know, so that's kind of the thing of like, well, I don't want my kid playing too many sports and getting fractures, and then do they get, you know, at higher risk of injury? No, that's a non-issue. Okay. I'm not saying fractures are good, but I'm saying they're not going to put you in a compromised situation later in life.